Hello everyone, it's an honor to be here today. My name is Austin Parker and I'm a DC student at Parker University. Today I'll be discussing this work, looking at initiating the Keele Startback screening tool in a chiropractic academic clinic. Before I get started, I'd like to acknowledge and thank my co-authors, Drs. Tam, Pohlman, and Malaya, along with Bryce Derry at the Parker University Research Center. The burden of low back pain is costly to both patients and society, and it's a burden that's projected to increase in the coming years. To combat the rising costs of low back pain, there's a need for clinicians to deliver care that is efficient, patient-centered, and high value. Efforts to deliver high-value care have aimed at subgrouping, classifying, and/or stratifying patients to better direct management. Many classification systems use diagnostic factors to subgroup patients based on mechanism of low back pain or expected response to treatment. In line with current consideration of the BPS model, classification approaches have included prognostic factors, specifically psychosocial risk factors, otherwise known as yellow flags. One of these approaches uses the Startback screening tool, a prognostic stratification tool developed, researched, and validated by Keele University. Administered to patients presenting with low back pain, the tool generates a total score and psychological subscore, which are then used to stratify patients into one of three groups corresponding with low, medium, and high risk of developing persistent low back pain-related disability. The tool is composed of 9 items, each with a possible value of 0 or 1, 1 implying the presence of and 0 implying the absence, adding up to a maximum possible score of 9. The 9 items correspond with these factors related to the patient's low back pain. Items 1 through 4, shown on the left in blue, are factors related to the patient's pain and disability. Items 5 through 9 are in black and correspond with psychosocial factors, otherwise known as yellow flags. Generally speaking, a higher score on this tool corresponds with a higher risk of developing ongoing disability related to low back pain. The tool is scored by first assessing the total score, which differentiates between low and medium high risk groups. If the total score is 4 or more, the psychological subscore is then used to differentiate between the medium and high risk groups. These risk groups are then used to stratify patients and inform treatment decisions. Management for low-risk patients is focused on providing reassurance of favorable prognosis, promoting non-pharmacological options, and supporting self-management. The goal for medium-risk patients is to restore function and minimize disability through non-pharma options, such as exercise and manual therapy, along with supported self-management. For patients in the high-risk group, management is more intensive. While the focus is on reducing pain and disability, there's an added emphasis on addressing psychosocial factors and comorbidities. Often, referral for multidisciplinary integrative care is indicated for these patients. In doing this study, we are particularly interested in the feasibility of using the tool in a chiropractic academic clinic setting. Additionally, we viewed this as a great opportunity to collect data on demographics and care outcomes of patients seen in the clinic. From March to April 2018, new patients presenting to the Parker clinics in Dallas, Texas were screened for study inclusion. Those meeting inclusion criteria were asked to complete the Startback tool. They were stratified into one of 3 risk groups and underwent a trial of care at the Parker Clinic. A chart review of the first 4 weeks of care was conducted for all respondents to track group parameters and treatments, as well as follow-up information. We looked at pain and disability using the numerical rating scale and Oswestry Disability Index, respectively, and gathered participants' expectations of improvement from care. These data were then classified according to treatment visit. It's important to note that neither interns nor providers were given any training over the tool. We wanted to see if this could be rolled out without training and used with new patients. We successfully screened over 180 new patients and were able to implement and use the tool with 87 of them. So we can conclude that it was easy to roll out without prior training and was feasible. Also, group demographics seen in this study were not unexpected. The demographics of the medium risk group fit closely with that of the typical chiropractic patient, that being the middle-aged female. The interesting finding from this study was the drop-off in return for eval after 4 weeks, which was low across all 3 risk groups, but especially low in the high-risk group, where 0 patients returned for 4-week follow-up. This is a big deal. These are the people at highest risk of developing ongoing disability. Not everyone in this group has suicidal ideation, but anyone with suicidal ideation is in this group. Thus, following up and keeping track of these patients is incredibly important. These are the people we simply can't let slip through the cracks. Of course, the next question we wanted to answer was why follow-up was so low. And here's what we think happened. This study collected data through the transition period between two scholastic terms. During this time, it's common for interns to go on vacation, leave student clinics for an outside rotation, or even graduate. Patients participating in this study were caught in this transition period, which could have easily affected their care. In this light, consistency and continuity of care through break periods is a unique challenge faced by many, if not all, chiropractic schools. Clearly, future studies should take note of these transition periods when designing protocols and interpreting results. However, the real issue is that these challenges do exist. Clinics should also design safeguards that ensure high-value patient care is maintained even through transition periods. It's important to acknowledge that the primary outcome was whether it was feasible to implement this without training, and the answer was yes. However, given the study was not designed to understand the continuity or consistency of care, it precludes a causal understanding of the issue. We also shouldn't be quick to draw conclusions about the secondary outcome measures, as there was a small sample size, especially in the high-risk group, and a high lack of follow-up. Because of this, more studies are obviously needed. Also, patient tracking could be done on a more consistent basis to better understand the nature of what happened to the participants. Overall, the Start Back tool was easy to implement, did not require training, and provided valuable clinical information. There's an obvious need for better means of patient tracking and follow-up, and this study also brought to light chiropractic academic clinics face a unique challenge for the continuity and consistency of patient care.